You want me to get started?
I just want to welcome you for being here today for BayCare Presents. We're so glad to have you. If anyone has any questions during the talk, please type them to the chat. We'll keep an eye on that, and we'll make sure that we get to that at the end. And with that, I'd like to introduce Dr. Huguet, who is here to talk to us about putting out the fire.
Hi, everybody. I appreciate you taking the time to join us today. My name is Dr. Kevin Huguet. Today, we're going to be talking about gastroesophageal reflux disease, putting out the fire, effective GERD management. I am currently the chairman of the Department of General Vascular Surgery. I've been in that position now for over a decade, and I'm the surgical director of the St. Anthony's Hospital Heartburn and Swallow Center, where we specialize in treating this disorder. And then I am the president and founder of the Minimally Invasive Institute of Surgery, which is our practice. So we'll go ahead and dive in, and we're happy to answer questions at the end. We do have some time set aside for questions at the end of the presentation as well. So what we're going to be talking about today for topics is GERD. It is a big and growing challenge. We're going to define it, talk about some complications to be aware of, talk about symptoms, how to manage them, how to treat them, and then finally the surgical treatment for GERD and what are the indications to undergo surgery for this disorder. So GERD is gastroesophageal reflux disease, and it is basically a constellation of different symptoms that are all labeled under the term GERD. When people typically think of GERD, they think of heartburn is usually synonymous with GERD. But GERD itself has a lot of different symptoms besides heartburn. And when we think of heartburn, it's basically that burning sensation in your chest from acid coming out from your stomach up into your chest. And it can be up anywhere from, say, your neck all the way down to, say, your breastbone or your abdomen. Acid reflux or regurgitation is where you feel the acid come in your mouth, and that's also a component of gastroesophageal reflux disease, or GERD is what we'll be saying moving forward. Some people have atypical symptoms of GERD, which would be like chest pain, trouble swallowing, and even things like a chronic cough or clearing the throat issue sometimes is attributable to GERD as well. So there's a whole list of different symptoms that we see, but the most common would be two things, which is heartburn and regurgitation. GERD is a very common problem, particularly in the United States, and it's a growing challenge. 1 in 5 U.S. adults suffer from GERD, and there's a medication called a proton pump inhibitor, which is kind of the last resort medicine that we use for treating GERD. And there's about 20 million patients on that medication, and 40% still have symptoms even though they're on it. GERD can lead to long-term complications, which we'll get into in a little bit, and that would be from basically acid bathing the esophagus. It can cause problems in the long term in a very small population of our patients. So GERD is from acid kind of bathing the lower esophagus, this area here. This is a diagram of your esophagus and your stomach. And GERD is where acid refluxes up into the esophagus, and it can go all the way up into your mouth, which is what regurgitation is. There's a couple reasons that cause it. And the most common problem is just a weak muscle here. That muscle is called your LES, or lower esophageal sphincter. And that's really what the basis for treatment centers around, is getting that in the right anatomic position and strength. We look at it as GERD is really being related to two causes. One is purely a sphincter issue, and that sphincter is that LES, that's the muscle there. And this is a diagram of pretty normal anatomy, and there's the sphincter right in this area. You can have a weak sphincter muscle there, and that allows acid to bathe the esophagus. Or other illnesses like obesity or even pregnancy, anything that increases your intra-abdominal pressure, it pushes on your stomach, and then the acid is more likely to come up into your esophagus because that muscle isn't strong enough to hold the acid down. Another is purely a structural issue, and I would say a lot of the patients to make it to surgery do have issues with a hiatal hernia. And a hiatal hernia is where that muscle, the lower esophageal sphincter muscle, isn't down in the abdomen where it's supposed to be. The muscle in part of the stomach has slipped up a little bit into your chest, which is what this diagram shows. So this area right here is supposed to be down in the abdomen, which is this area down here, and this muscle right here is your diaphragm. That's here, and here is the diaphragm, and that's what separates the chest from the abdomen. So a hiatal hernia means it's not a hernia you see it on the outside. A lot of patients think they see a hiatal hernia externally. Those are different hernias. This is a hernia purely on the inside that you can't see externally, where that muscle, that LES, that sphincter muscle, has slipped up into the chest, and the change in anatomy makes a person much higher risk to get reflux disease. So one of the key components when we do surgery for reflux is to fix that hiatal hernia, to put it in the right position. If left untreated over the long term, GERD can cause inflammation of the esophagus and erosion of the lining of the esophagus, because what happens is the acid bathes this part of the esophagus, and then it kind of irritates the lining, and that's called esophagitis. And a lot of times when they look at that area on endoscopy, they'll grade how bad that inflammation or esophagitis is. Sometimes that scarring can lead to ulcers in the area that bleed, or erosions in the area when you have severe reflux disease. Over time, if not treated, these symptoms or these issues can lead to strictures. And a stricture is where you get this narrowing here. And with the narrowing, you can have trouble swallowing foods, where they feel like it sticks in your chest after you eat it. And that's from all the scarring in the area from acid reflux disease. Usually, if a patient gets to the point where they have a stricture from scarring, they have a pretty severe acid reflux disease, and that's one of the complications that we think about an operation for if it's bad enough. In time, this scarring can lead to something called Barrett's esophagus. And studies have shown that Barrett's, which is where the lining of your esophagus, right there at that sphincter muscle, these cells in that area can undergo changes. So sometimes they can tell by looking at it, and usually a biopsy has to confirm it, that they do on an endoscopy. But they take samples of these cells and they look at it under a microscope, and they see that the cells have changed, and they start to transform into different appearing cells that they call Barrett's esophagus. Barrett's itself is considered a precancerous lesion. And that doesn't mean you're guaranteed cancer, but it's something that they do have to watch to make sure it doesn't turn into something that could be cancer later. And so it doesn't mean that all patients that get acid reflux are going to get cancer, because that's not the case at all either. But it does mean that it's one of the risk factors that we like to be aware of when we're evaluating patients with reflux disease. And usually the time that they start screening patients for problems, if they've had reflux, say over 5 years, and it's severe reflux, then it's time probably to have an endoscopy with your gastrointestinal doctor. But Barrett's itself only develops in about 10 to 15% of patients that have reflux disease. And then a very small percentage, we're talking 0.5%, go on to develop changes that turn into esophageal cancer. And esophageal cancer it's a rare event with reflux disease, but something to just be aware of. It's the 11th most common cancer in the U.S. And there were about 22,000 new cases just last year. And we say 0.5% of Barrett's esophagus patients per year can get diagnosed with esophageal cancer. But first, you have to have reflux, and then about 10 to 15% of those people can turn into Barrett's, and then a 0.5% of those Barrett's patients then turn into esophageal cancer. So if you do the math there, it's a rare event, but just something to be aware of. And I don't want to bring this up to alarm anybody, to make them think, oh, I've got heartburn, so I have cancer. That's not, don't take that message away from this. That's not the case. It's a rare event, but something just to be aware of and educated about. So how is GERD diagnosed? Well, there's a couple ways to do it. One is just a trial of an antacid medicine to see if your symptoms respond to an antacid. That's usually the best test, if your symptoms are acid related. So a lot of times it's a trial of one of the stronger medicines, which is called a PPI. That's a proton pump inhibitor. And a lot of times an upper endoscopy is an easy way to do it. They look at the lining and see if there's inflammation or evidence of acid reflux has been ongoing. And then sometimes, if there's a question, we'll order what's called a Bravo study. And that's a procedure where they go in with the endoscopy and they put a little microchip on your esophagus, and it sits right there where the acid bathes the area, and it monitors the amount of acid exposure and gives us a number for how bad the acid exposure is. So this sometimes is used in patients that we're trying to decide if they benefit from surgery. Order this test to get a number for how bad their acid exposure is, to give us an idea of how well they would respond to having an operation. So once we've decided, yes, we've got GERD, what do we do? What are the management options? Well, there's symptom treatment or management, and then there's just plain out treatment. Symptom management would be, behavioral changes. And behavioral changes would be like avoiding foods that cause acid reflux. And there's a list of foods shown here. And typical foods would be things like spicy foods, fatty foods, tomato-based foods, alcohol, carbonated drinks. All of those are potential triggers for that lower esophageal sphincter muscle to loosen up a little bit. And then acid can bathe the esophagus and cause reflux. There's a lot of other behavioral modifications we recommend to patients with reflux to control symptoms, and some of those would also be elevating the head of your bed, and that can be either done with like bricks or blocks or a bed that does like in the picture here. Sleeping on multiple pillows to keep your head elevated to prevent the acid or regurgitation. Because a lot of times when you lay flat is really when the regurgitation happens. It's because your body's flat. And so we use gravity to elevate the head of the bed so it's less likely that acid will come up. And then also we try to avoid eating 4 to 6 hours before laying down, and there's less likely that acid will come up into your mouth at night as well. So those are the dietary or the behavioral changes we go through, and then we move on to medication treatment. There's simple, immediate response medications that aren't long-lasting, and those are the simple antacids people are aware of, like Tums, Rolaids, Pepto-Bismol. And then there's more intermediate grade, which are the H2 blockers. These are histamine blockers, and these are things like Pepcid, which is famotidine, is probably the most common one. It is something you buy over the counter, and it does control acid, not to the extent that the proton pump inhibitors do, but for mild reflux disease that happens occasionally, it's usually a safe medicine you can take in the long term. And onset is about 20 minutes, and it lasts usually for 12 hours. So you can take this one twice a day, or some people take it before nighttime if they get mild symptoms at night. And that's a safe medication treatment that has minimal side effects, relatively inexpensive, and you can do for a long time, and it really won't have any side effects. The proton pump inhibitors are kind of the final step in treating acid medically. And those are things like omeprazole, Nexium, Prevacid. Those are the medicines that really knock out most of the acid. And so that's the final step in treatment. And so when patients make it to the proton pump inhibitors, then they start considering an operation for multiple reasons at that point. But I definitely wouldn't jump from having mild reflux to taking something that strong. I probably would recommend, if you have mild reflux disease that's controlled mainly with diet, occasionally breakthrough attacks, to just use the histamine or the H2 blockers like Pepcid. The benefits of medications would be that, it does control symptoms, majority, but not all of the time. I would say 60% of patients say it controls their symptoms, and then you have those outliers, about 40% that it's not working. It does provide good relief from heartburn and for people that it does work, and it can reduce some of the inflammation of the esophagus. But once you have it, a lot of times if there's not something that's causing it, like pregnancy or obesity, it can be a lifelong commitment to be on the antacid medicines. And the other part is it does prevent acid from coming out, but not liquid or regurgitation often, because that's more of a structural issue with the muscle that's stopping the liquid. And this just shows kind of a response rate to medications. On average, somewhere around 60% have response, and 62%, that is 38%, can have breakthrough attacks. So when is it time to think about surgery? When is surgery a good option? Well, there's a few scenarios that usually encompass about 90 to 95% of our patients. And that would be, number one, if you are taking really strong PPI or strong antacid medicines and you're still having breakthrough attacks regularly. Those are the patients with severe acid reflux, and maybe something like an operation is needed. Another instance would be if you don't want to be on a proton pump inhibitor for the long term. And there are some concerns about long-term side effects of using these medications, and some population studies have shown potential issues with various comorbidities or things that can come up from it. And we don't have hard science yet to prove it, but there is some soft data in regards to things like osteoporosis, kidney function issues, dementia. And so patients oftentimes don't want to be on these medicines long term, and so they want to have an operation so that they can get off of these medicines in the long term. Some patients just find taking the medicine inconvenience, or there's a cost aspect of it too. So that's number two would be you don't want to take GERD medicine. And the best surgical candidate is somebody who has typical heartburn and the medicine works and they want to get off of it. Those patients have just probably 95% response rate to surgery. And then the third indication would be complications from GERD. That means you've got severe acid reflux, and it might be something that requires something more drastic like surgery rather than just medications. And those complications would be things like strictures, ulcers, or even Barrett's at times if it's not responding to just medications. So how does surgery work to prevent acid reflux? Well, surgery really has two things that we do to basically restore the reflux barrier, because that's our goal here, is to tighten up that muscle so acid stops coming up and fix the hiatal hernia. So those are the two steps: repair the hiatal hernia and restore the acid valve, the LES, by reinforcing it. And so the first step to all reflux surgeries is we fix the hiatal hernia, and that's where your stomach's pushed up here into your chest. This is your diaphragm. So step one, we pull that stomach down where it's supposed to be, and then we stitch up the diaphragm to prevent it from going up there again. And then step two, once it's in the normal position, then we somehow reinforce this sphincter muscle to reinforce the valve so acid stops coming up. So the way we reinforce that valve is to restore the sphincter muscle that's there. And so we can do it by wrapping your own tissue around the valve to tighten it up, and that's called a fundoplication. Or we can use magnets in the area and wrap magnetic beads around there, and that's what's called a LINX device. That's magnetic sphincter augmentation. So the types of anti-reflux surgery are listed here. There's laparoscopic fundoplication, where we wrap your stomach around the esophagus. There's magnetic sphincter augmentation, where instead of your stomach, we put a valve or the magnets there. And then there's what's called a TIF, which is transoral incisionless fundoplication. So the laparoscopic fundoplication is shown here in this tube, in this cartoon, is your esophagus, to give you an idea how this looks. And we basically take your stomach and wrap it around the esophagus, and that stomach wrapped around the area basically creates an acid reflux barrier, so the valve is reinforced and acid stops coming up into your chest. This is basically the gold standard for treatment of acid reflux disease surgically. We have the longest experience with this operation, and in my opinion, the best results with this operation. We've got data dating at 5 years, 10 years, and then this review was 20 years of data. And it showed that up to 90% of patients are satisfied, and 95% say they would have surgery again. And so it's a good operation. It does have an incidence of gas bloat in up to 10% of people, and somewhere around 3 to 7% of patients can have a little bit of trouble swallowing. It often goes away in the long run. The ETIF, or the transoral incisionless fundoplication, is an endoscopic procedure where they try to recreate what's done surgically. It is a much newer procedure. We're lacking some long-term data. And one of the key components of surgery, which is a hiatal hernia repair, is not done with this. And so often a lot of patients can't have the hiatal hernia fixed during this operation, and so it doesn't work as well for that patient population. And then there's the magnetic sphincter augmentation, which is the LINX Reflux Management System, and that's these magnets that go around the esophagus. And basically, instead of using your own tissue, we wrap the magnets around the esophagus, and they keep it closed and allow food to open up. I have a video if it'll show up well here. And so basically the way it works is, I'll see if I can blow this up. It's magnetic beads. They go around the bottom of the esophagus here. It links together, and then it stops acid from coming up. So it holds it closed. And then when you swallow food, it allows the magnets to open up, and that permits food to move through, and then it closes the sphincter muscle again. So this operation is it runs. Let's see if I can get this to. It's done the same way in the same incisions, for example, that you would do for the Nissen or the other operation. So it's the same incisions. You're having the same surgery with a hiatal hernia. It's just you decide to put magnets in instead of wrapping your stomach around there. And it can be an outpatient procedure, so that part's really nice. People rather go home. It's less invasive because we're doing less surgery to rearrange your stomach, and so you don't have as much risk of a gas bloat. And the response rate is very good, so it's durable for heartburn, particularly regurgitation. And another nice thing is it is reversible if patients don't like it for any reason. I think the big sticking point with the LINX is what we're finding, and it's been around for longer than 10 years, and I've done them for over 10 years myself, is just the dysphagia rate we're finding is patients have a hard time swallowing in about 15% or more. And so that sometimes that can get pretty troublesome. So if anybody in the screening interview has any trouble swallowing, then usually I don't recommend a LINX because I don't want to make that worse. And so that's I think the big standout for the LINX, other than all those good things we've listed, is just trouble swallowing. And then you can have an MRI usually. There are some MRIs that can be done, but they're very, very weak MRIs, and so that's another challenge if patients frequently have MRIs. And there's a small chance of device failure too. But the LINX, just like the Nissen, has been reviewed in long-term data in 5 years and even some 10-year data, and shows similar outcomes to the Nissen. I think the Nissen's still more effective. The LINX maybe for severe reflux patients may not be as effective if they've got severe acid reflux. So, so what are our take-home messages in time what we talked about today? So GERD is really, it's primarily a failure of the lower esophageal sphincter muscle. It's a mechanical failure. And so when we take medicines for that, they can help symptoms, but they don't really address the underlying problem, which is weakness of that muscle down there that's supposed to be stopping acid from coming up. And so when you take the medications, they can stop the burning sensation, but liquid potentially still comes up and can cause regurgitation symptoms, but maybe not necessarily heartburn symptoms. And then surgical options would be the 3 options we talked about, and that would be the fundoplication, the LINX, and then less commonly would be the TIF procedure. And these days, surgery is very safe, very effective. Patients are generally very happy with it. But we do have a screening protocol for a lot of patients to decide if they're candidates to undergo reflux surgery. And it's not something we generally don't jump into surgery as soon as somebody mentions that they have reflux disease. We like to make sure, number one, that they've tried medical management first, and something as simple as the H2 blockers we talked about, the Pepcid. If they need to escalate it up to something stronger, well, then that's when surgery conversations begin, is at that point. And then also if they're not responding to medications, those are the times that we think about, okay, it's time to think about one of these surgical options because a patient's miserable and they can't have good quality of life because they have such bad acid reflux disease. So I think that wraps us up there. That's our presentation. I enjoyed chatting with everybody today. We can open the floor if we've got some questions to go over.
We got bunches of questions. I've kind of clumped them a little bit. So if you put your question in the chat, it's not I'm ignoring some. I did kind of put some of them together. I think one of the ones I want to start with, because you mentioned this towards the end, is people wanted to understand about the LINX, that they can't have an MRI. And you did mention that that's not something they can do. What else could they do if they needed to have a test like that? Where would they send them?
Well, there are MRIs that you can have, but they are weaker magnet MRIs. So they base it on the strength of the magnet. And I think it's less than 1.5 Tesla. And so they just need to find MRIs that are LINX compatible if they have to have one. If, for example, somebody gets regular MRIs, then I usually say, well, maybe we shouldn't think about a LINX because at some point it might become a problem for you.
And then if someone was diagnosed with Barrett's, how often should they be getting screened at that point in time?
Well, normally it depends on the biopsy results from the initial Barrett's diagnosis. And then there's guidelines that the gastroenterologist follows based on if there's low-grade dysplasia, no dysplasia, or high-grade dysplasia. So a lot of it will depend on the biopsy and whether there's any changes in those cells. If it's a low risk Barrett's, sometimes they do it every 5 years.
Wait, someone else was talking about that they were diagnosed with Barrett's 15 years ago with an endoscopy, and they have it every 3 years, and every biopsy after the initial one has showed no sign of Barrett's. Can it heal itself? What could be going on there?
So yes, it can often, and that's why people take PPIs. And so usually the PPIs will usually cause reversal of Barrett's, which is why they have to stay on it and have follow-up screenings to make sure that the PPIs have worked.
And this one, I'm not sure if you
the
can.
answer is you want it
Yes.
to go into remission.
Perfect. And this one, I'm not sure if it's, that you can answer it clearly, but they want to know what causes a hiatal hernia, and is it secondary to GERD?
So I think it's flipped around the other way. So a hiatal hernia is frequently what causes GERD. And the reason is that the valve with a hiatal hernia is in a different environment when it moves up into your chest. And so with that, it causes a negative pressure on the valve, and then it doesn't work as well. And so it's the hiatal hernia that generally causes the GERD.
And I know sometimes you talked about pregnancy, obesity. Is there an easy thing like, oh, hiatal hernias, I want to make sure I don't do this so I don't get it?
Say that again?
Can you prevent a hiatal hernia?
Oh, not really. It's not something like hernias on your body where people are, worried about causing them or making them worse. Risk factors for hiatal hernias, one of the biggest would be things like obesity, or I'd say, I guess chronic coughing can do it, but obesity is probably the biggest risk factor because it's causing pressure on the diaphragm and pushing the stomach up.
So obesity is our big thing that we can work on, but that's good.
And that's also a risk factor for reflux disease, obesity as well. So a lot of times by reversing the obesity, the reflux gets better.
And I think that rolls into that next question I have here is, why is this such a big and growing challenge in the United States? There's so much more of this being talked about. They're wondering, is it due to our diet and I'm going to put our inactivity?
Oh, the GERD?
Yes.
I think it's probably more, I'm going to say, a lot of it's dietary related. And I think a lot of the foods that we eat probably are associated with relaxing that lower esophageal sphincter and causing it to be more prevalent. Reflux also, your diet for reflux disease is often a healthier diet. So if you're on a diet that is altered to prevent acid reflux, it's usually healthier things. And I know firsthand because I get acid reflux, and if I go on a strong medicine to go on vacation or something, I'm eating whatever I want. But if for example you're on an appropriate diet to prevent acid reflux, it actually keeps you on a healthier diet. So I think that's probably playing a big role.
Someone asked about their brother died of GIST, and I'm not sure if that was a miss of letters or if you know what a GIST is, all capital. Is this something hereditary that they need to be aware of for their children and their family?
Well, that is completely unrelated to.
Okay.
Yeah, that is a growth or a tumor on the stomach. And so it's not related to what we're talking about today. But depending on the aggressiveness of the GIST that was removed, the size and multiple factors, it can be related to family history. And so they probably want to steer that question towards their oncologist.
Very good. That's always go back to the source that you learned this from.
Mm-hmm.
A lot of the next questions are all due to medication. So we had a bunch of people wondering is there a risk of osteoporosis with some of these medication? And, what are some of the long-term risks that we need to be aware of as we're taking these?
So, there is concern in population-based studies that the PPI can increase risk of osteoporosis, particularly in women. And so if you're going to be on the medicine long term, you should definitely follow up with your primary care doctor and get your bone mineral density checked and make sure you probably supplement with appropriate calcium and vitamin D to make sure you're getting enough preventive factors in there to prevent osteoporosis.
Does it affect digestion at all, especially with the proton pump inhibitors because of the decrease of acid?
There is some question mark about that out there, and because it is altering kind of the way your body was built to be. And so your stomach was built to make acid, and you basically stop the acid. So some people do have effects from being on a PPI, and another reason they don't want to take them, they can get some diarrhea or digestive issues otherwise besides reflux. And so it also has a propensity to get an infection in your colon. It's called C. diff. So there are some other things that can happen from being on long-term acid suppressive therapy.
Someone was asking about what can they do to help with silent reflux. I'm not exactly sure what that is.
Well, silent reflux, we treat the same way as typical reflux. And sometimes silent reflux can be somebody has a chronic cough, they have different sensations where they don't necessarily have typical heartburn, but in their larynx, they may have a sensation of what's called globus, where they can't swallow correctly, like something's just constantly stuck there, a lot of throat clearing, coughing. And so sometimes ENT doctors will see those patients and diagnose them with silent reflux. There's another disorder called, or similar to silent reflux, called LPR, or laryngopharyngeal reflux. And those are kind of grouped together. And except the LPR symptom are actual symptoms rather than being silent, but you kind of manage those the same way: lifestyle modifications, medications, and then ultimately surgery if we find that these other things aren't working.
With that silent reflux, do you see a lot of excessive burping or anything like that? Is there a lot of gas release?
Yeah, you got so burping and gassiness, that's typical like GERD symptoms. So silent would be somebody has, for example, Barrett's, and they don't ever talk about having acid reflux, but they do an endoscopy for one reason or another, and they're finding changes in the esophagus that show that you are getting acid reflux, and it's showing inflammation or Barrett's, but they may not be feeling it.
Are there any polyps associated with Barrett's?
It's not the same sequence where you get polyps and then the polyp changes. Usually it's just changes in the cells where you don't necessarily get a growth. If you do get a growth, then that's a little bit farther along towards cancer. But usually it's just the cells change. They first turn into Barrett's, which is appearance under the microscope, and then they turn into what they call low-grade dysplasia. And it's a sequence, low-grade, high-grade dysplasia, then cancer that the cells go through as they change. But you don't usually get polyp growth.
Is the only definitive diagnosis for GERD through an endoscopy, or can another test kind of confirm that it's there?
Well, the definitive test is the upper endoscopy, or the Bravo study, which does an endoscopy as well. Beyond that, it would just be the trial of medications to see if it controls the symptoms. But those are the only tests. Sometimes you can do an X-ray called a barium swallow, and on the X-ray, after they swallow the contrast, they actually see acid come up. But that test is kind of just one particular point in time, and it's not as reliable for true acid reflux.
While someone's undergoing the fundoplication surgery, can they be doing another procedure at that time also? I guess someone might have to have two things done.
So rarely do we do two things together. Usually I do just fundoplications all by themselves because it's a bigger operation.
I'm scrolling through to see if I've missed anything. I think mostly with the medication and the time, I think you've discussed those. I do think we talked a lot about nutrition as a big part of this. Definitely going back to the doctor that you're talking to is important. But what about the thoughts of going maybe to see a registered dietitian too, who can look at some of your bigger picture, because maybe you have some other medical history going on also? What are your thoughts there?
Yeah, I think that dietitians can definitely teach patients about food triggers and typical foods to avoid. Or patients also could just tell from a food diary or writing down when they're getting reflux and then listing the foods that cause that reflux, and then they can know which ones are particular triggers for those patients.
You talked about the histamines being fairly safe and that you could take them for a long term, and that the PPIs are a little bit more aggressive. Is there a PPI that someone can take for life, or is this at a point in time where you have to go get surgery at a certain point?
I think that the PPIs are kind of all grouped together. There's newer ones coming out that are a little stronger, but in general, a PPI is a PPI in regards to these long-term risks that we see. Sometimes patients just have bad times and good times, and they can take a PPI, and usually it recommends they just take it for a couple weeks or even maybe a month or two. But in those patients, if they just need PPIs here and there, I think it's okay. It's the ones really that have to be on it for the rest of their life that there's some definite concerns, and it's worth deciding if they want to do that for forever or switch over to something like surgery.
Someone had asked if they only have heartburn just occasionally, is that having GERD, or is that something that they want to keep an eye on, but if they're only having it occasionally, maybe it's not GERD per se?
You know, if it's heartburn occasionally, that's actually more the typical patient that we see. I'd say that's the majority of people. And those are patients that can either get by with a Pepcid if it's bad enough, or just taking some Tums to get rid of the symptoms immediately. But those are not necessarily people that, if it's just occasionally once in a while, maybe wouldn't be something I'm too concerned about with needing an operation.
What do you think about gastric bypass for helping with GERD?
So if you have a patient that meets criteria for weight loss surgery, a gastric bypass is a good option. And that would be somebody, say, with a BMI over 35 or 40, depending on their condition, with acid reflux disease. A lot of times, if we're talking about weight loss surgery, we're going to recommend the bypass because the bypass does take the acid away from the esophagus. And it helps two ways. Number one, the weight loss helps with the GERD, and then also the bypass physically pulls acid away from there, and so that can help with GERD as well.
Do you have any thoughts on intermittent fasting and how that affects it?
You know, there's in regards to data comparing intermittent fasting's effects on GERD, I've not seen that. I can see how it would help it though, because you're basically decreasing the food load in your stomach and the acid production. And so if somebody's doing that, I would say that probably would maybe help with their acid reflux. I don't have any data to tell you there's science behind it though.
We have someone specifically wanting to know if you take UMR insurance. Should I just have them call your office?
Yeah, we do, but yeah, sure, call the office and we can go over the plan. Absolutely.
So I think that is it. I want to thank you so much, because this was a wealth of information. I think a lot of people suffer in silence and they don't really know what's going on, and they're causing damage inside their body over time. Whereas if they would go and talk to someone, there might be a path that can give them better feelings. So really appreciate you taking your time and giving us all this great information. We will send a follow-up to everyone on the call. Obviously, Dr. Huguet would love to see you if you need to, so you can reach out to him. But if not, this is just some information to kind of store in the back of your head if you come across someone, or if in your life something changes. But always make sure you're reaching out to smart, brilliant people who are out there and caring for you, so that you get the best information that you can to take care of your own health and well-being.
Wonderful. Well, thank you. I enjoyed chatting today. And always happy to see you in the office if you ever want to talk about reflux disease.
Thank you all for being here. I did drop in what next month is, and that is actually going to be just about moments of health, talking about all the things that can impact your well-being by taking little movement snacks and little moments of health that you can benefit from. So look forward to hopefully seeing you all next month, and enjoy the holidays.